All right. Looks like we are getting the live feed going. Always a little bit hard to tell how quickly we got connected. I've had to do a couple upgrades overnight because my dog ate the wire going to our carriage house where I do the filming. So last night I did a little bit of wire work and troubleshooting. Looks like our stream is probably fully alive now. We've got some new news basically overnight with our governor outlining a plan to go ahead and open up tattoo parlors, nail studios, and barbershops this weekend, which honestly is rubbing a lot in the healthcare community and scientific community a little bit funky, understandably. We have a quick update on the stats since it looks like we're fully live, fully clicked on. Here we go. So 2.5 million cases of coronavirus in the world. In the USA, 790,000 now confirmed COVID-19 positive test results. Probably somewhere like 5 to 8 times that amount truly, if you were to really fully measure every single person in the country, how many people have had coronavirus exposure and reaction in their system. Deaths worldwide now, 172,000 deaths worldwide, 42,500 in this country. Our last podcast last Thursday, 5 days ago, we were reporting about 30,000 deaths at that point. So we're up, nearly 50% in the last 5 days. Now that is a little bit of a slowing, which is very much a good thing. Still, we're clicking at 1,900 deaths per day in the USA. That was yesterday's number. I think last week it was more like 2,200 per day. Still, that is the number one leading cause of death in the USA now, above heart disease, above cancer, is coronavirus deaths daily. Of interest, yesterday in Georgia was a spike day too. 80 deaths per day recorded yesterday in Georgia. Now, Brian Kemp, our governor, decided to basically go ahead and open up parts of the Georgia economy. Now, the Georgia economy is very diverse. We have extremely rural areas and we have much more metropolitan areas. Undoubtedly, a lot of his input is going to be influence more some of those more rural areas. I will, though, this is a graph of sort of where we're at with daily reported cases in the state of Georgia. The number two on the graph here, this is the day that Governor Kemp decided to kind of issue a stay-at-home or shelter-in-place order for the entire state. You see we were clicking away at about 500 cases a day at that point. And then you see now today, or yesterday rather, April 20th, we're a little bit more, maybe 750 cases a day at this point when it was decided that the shelter in place should be opened up. The point number one was about March 16th. This is the day and the week when most medical offices got really serious, medical and dental offices got really serious about either very strict screening protocols coming into their offices, social distancing, spacing appointments more, etc., or even some closed down certain branch locations. So you see, this is kind of the state of the beast right now. We're at elevated case count increasing per day than we were when we closed down. We are going to be opening up soon, though. It sounds like slowly. Deaths per day. So probably regrettable the day that Governor Kemp announced that we'll be opening up. We have seen a several-day trend of increasing deaths in the state, including a pretty massive spike yesterday. Now, probably some of that yesterday date was recording over the weekend. As we notice, we have sort of a down day Sunday and Saturday, and then a spike up. But basically, we're not really having a downward trend in the death rate at all, which is, of course, unfortunate. And then we will circle back to our Sweden story. In Sweden, we have a sort of a non-governmental imposed lockdown. It's mainly a recommendation to stay indoors, a recommendation to self-isolate. Sweden is, I believe, the largest of the Scandinavian countries by population, and it's been basically pretty controversial in the medical and scientific field about how they're approaching this, sort of unlike practically every other country out there, without imposing strict government lockdowns. And if you want to see what they're doing, their curve, Sweden's curve, continues to sort of outpace the remaining Scandinavian countries, as you see there. Now you might say, well, maybe the last couple days, maybe it's leveling off a little bit. It could be. By reports on the internet, there's a pretty strong sort of social movement to distance in Sweden, even though the government is not strongly requiring it legally. So if you're just joining us, I'm Dr. Aaron Rogers, ear, nose, and throat doc in Atlanta, Georgia. We're coming to you with coronavirus updates a couple times a week, Tuesday and Thursday mornings, 9:30 in the morning. Today we've got a special guest, slightly pre-recorded, Dr. Michael Johns from the USC Keck School of Medicine, as well as who's a laryngologist, basically an ear, nose, and throat specializing in voice and voice disorders and how this might impact COVID and seeing our patients during this time, as well as a local speech therapist and voice coach, Eva Sullivan, who has worked with our office here and has worked with me collegially in the community for several years now. So we'll go ahead and turn it over to that pre-recorded interview, and then we'll join you back at the end. Thank you.
Good morning. Today we have some special guests with us. We have Dr. Michael Johns III, Los Angeles voice specialist at USC's Keck School of Medicine. He's Hopkins, Michigan, Vanderbilt trained ear, nose, and throat, and laryngologist or voice box specialist. His research interests and areas of treatment include surgery on the vocal cords, surgery on the windpipe, and addressing patients with a variety of these breathing and voice problems, including the professional voice. Dr. Johns?
Good morning. Thank you, everyone, for listening in. And Aaron, thank you for joining me. And it really is a pleasure to see Eva, who we've worked with many, many times over the years.
Yes, and you mentioned Eva Sullivan. She's a locally trained and licensed speech pathologist specializing in classically trained voice work, herself being a veteran performer at the Atlanta Concert Opera and a voice coach for aspiring talent, as well as many professional voice users in the Atlanta entertainment scene. Thank you, Eva, for joining us.
Thank you for having me. I'm happy to be here and happy again to see you, Dr. Michael Johns, as well. It's been a while.
Excellent. Dr. Johns, can you talk a little bit about your practice and your typical patient population? What do you see?
Sure thing. So heretofore, before all of this, I was in a relatively obscure field, and it is small, otolaryngology, or ear, nose, and throat doctor, ear, nose, and throat surgery, and I've specialized in laryngology. ENT, believe it or not, is divided up into 7 subspecialties, and laryngology, basically the T of ENT, from here to here, is what my practice and really my expertise focuses around. That's voice, swallowing, and airway problems that people may have.
Got it. And Eva, many speech and language pathologists see children or work with the elementary age children, but I understand your practice is a bit different from this. Can you tell me a little bit about your specialty and your expertise?
I started out as a singer, musical theater, and then into opera, which is ironic because I was at the University of Southern California, where Dr. Johns is now at the Voice Center there. And then my master's study in speech pathology and singing, opera performance, which then took me to my clinical fellowship training at Emory Voice Center. And after, I would say, 10 years of doing mostly speech pathology, I got back into the singing world. So I've been singing with the Atlanta Opera Chorus. I've been doing roles with Capital City Opera here in Atlanta. I was supposed to cover a role at Opera Birmingham during all this, and then that performance was canceled. Atlanta Concert Opera, you mentioned, is supposed to have something in October. So we're hoping everything gets back to normal soon and we can all start singing again. But right now, with my own company, I work with about 6 different ENT practices in the greater Atlanta area.
Excellent. Thank you, Eva. I wanted to kind of bring this conversation back to the current coronavirus pandemic that we're all dealing with and all adjusting our lifestyle and our practices to. We have recently, the last couple of weeks, from the CDC and the Surgeon General, a recommendation for wearing face masks in public. The argument here being that we can unknowingly spread the virus in our speech or even in our breath as we're just going about our daily business. The lungs and the voice apparatus is apparently very efficient at producing large amounts of airborne particles or aerosols that can travel quite great distances and infect others. We have in the voice world this horrendous case of the Skagit Valley Chorale, which was near Seattle, Washington. Early March, this community choir met for a rehearsal, And a little bit of reluctance in meeting early March in Seattle. They did have about an hour outside of Seattle. They did have a number of coronavirus cases hitting there, and quite the the nation's first hotspot. About half the chorus attended, or about 60 of the choral members attended a relatively regular and routine rehearsal that they had. There were some observation of social distancing, but it wasn't quite intense. No one was wearing masks, and no one was 6 feet apart from each other, for instance. However, the real horrendous thing was within about 2 or 3 weeks, some 45 members of that chorus had fallen ill with coronavirus, and 2 members had subsequently passed away. So the argument here is that when people are speaking robustly or speaking loudly, maybe much like we're speaking into our microphones right now, or when they're singing, or especially singing loudly, we're making these aerosols in the airway, and these aerosols can easily travel and infect others. I don't think this is something that we've really seen a lot and focused on a lot in the ENT world, given that we're sort of constantly right in our patients' faces every day. We're talking very closely to our patients, and certainly in the voice subspecialty, in the voice fields, we're very much dealing with a lot of these aerosols, and previously have not had real intense mitigation strategies. So, Dr. Johns, I've been around ENT offices, basically my entire career, the better part of my life now, and I've never seen aerosols and droplet precautions treated quite so seriously. How has your practice changed lately, and do you think we now have special risks that we must deal with?
Yeah, well, lots changed, that's for sure, for all of us, and it really stems from the unknown and the uncertainties that are out there, and with unknowns and uncertainties come natural anxiety, and then taking action in times of unknown and uncertainty generally is best directed towards erring on the side of precaution and safety, and so. As it pertains to our specific practices, we've effectively have shut down all routine in-person clinical care. So we're seeing our patients via telecare appointments and for all initial encounters. And we, at that time, will make a risk assessment as to what's going on and whether an interventional procedure, whether that's a diagnostic laryngoscopy or a surgical procedure, is warranted at that time. And we've really limited in-person activity to emergent and truly urgent situations. And so the day-to-day operations have really scaled down substantially. And I expect it to remain that way for at least certainly the next several weeks and possibly longer until we get a better handle on the issues that we've all been stressors for us. The testing, immunity, personal protective equipment, and just navigating the clinical operations, a waiting room, cycle times on our clinic rooms, appropriate processing of that. So it's been a lot of work and development as we try to navigate this in the myriad of unknowns that we're facing.
Eva, have you had to change your day-to-day operations, your practices? What kind of additional precautions are you taking doing voice training, voice coaching, and routine SLP work?
You are looking at my online setup for teaching voice lessons. So it's been several weeks now that any singing lessons that I've been doing have been online, which is definitely a learning curve for a lot of us who are used to getting that in-person, auditory, nervous, empathetic energy from those that we're working with, but we're making it through. I have done quite a bit of telehealth, but I have to be honest that most patients are in a waiting phase, that if it's not urgent and it's not something that they feel comfortable working on right now, they're postponing appointments even telehealth-wise till later dates, till they maybe have a better understanding of financial issues or insurance coverage for those services. And if I do see any individuals in person, I am able to adhere to 6-foot distancing precautions. However, we still don't know for sure how much just talking, how much just breathing, loud voice production, singing even, how much that generates into the air like Dr. John said, how much time in between patients, aeration of the rooms, and certainly the cleaning protocols. So I have done very little in-person outpatient work, and then I do some acute care. And I've asked several of my voice and swallowing colleagues some of the precautions that they're doing, including full PPE, N95, face shields, gowns, for all swallow valves, to only doing telehealth and telepractice for swallowing of valves for COVID positive or persons under investigation. So there's a variety.
Yeah, certainly we have this current, very contemporary hot topic of exactly how much are we suiting up and gearing up. I'm wearing goggles in the office and face masks in the office with all patients. And if we're doing any procedure, I'm upping it to an N95 face mask, if not a full PAP or a PAPR system, which is just crazy to even consider 2 or 3 months ago going through all of that. So my question really is, do we think this is going to, how long do we think this is going to continue? And if this extra precaution continues much longer, where are we going to find ourselves August, September, October, in the fall season again, when things might be picking back up? Are we still going to be suiting up, gearing up to do what used to be just our daily activities? It was pointed out to me that dentists, for instance, mask up and goggle up or use a face shield practically every time they look in someone's mouth. And maybe we should be doing the same thing. Dr. Johns.
I think it's certainly going to look very different as we emerge from this, and I certainly am no expert in infectious diseases and transmission of infectious diseases. And the conversation right now, as we, fingers crossed and knock on wood, hopefully are getting some positive news regarding mitigation of the situation. Where all the conversations are starting about how can we safely start releasing the brakes on some time-sensitive care that we need to be providing patients. There's a lot of things that we do that may not qualify for what that emergent or urgent categories that we're providing in-person care for now, but delayed too long can lead to adverse situations down the line. And so that's kind of where the conversation is now, is how can we sort of safely get back to doing the things that we need to do. And so I think we're gonna know more week to week as we go through this. But certainly it's not gonna look the same, certainly until we get into the post-vaccine or effective treatment situation for this.
Right. I mean, I know that you're very involved with awake procedures on patients for a variety of conditions, some of them purely sort of quality of life conditions, other conditions may be pre-malignant, or patients who are post-stroke or post-neural deficit, who are really having some difficulties. And I know we're kind of itching to get back to it, but I can't help but think that a lot of those patients are going to be in that sort of higher risk category for a higher risk of spreading conditions to others. Eva, do you have any guidance? Have you had any guidance from like ASHA or some of the other speech pathology groups out there as far as what is appropriate PPE for routine visits, or you mentioned for swallowing studies that you may be doing in the hospitals?
At present, the recommendation is anything that can be done via telehealth should be done via telehealth. They're pushing very hard to make sure that these procedures and visits are covered for patients, but there are certainly things that have to be done in person, especially in the acute care settings. But at least from my conversations with my colleagues, that different institutions are applying ways of interpreting what the governing bodies are telling them. In terms of how much PPE your facility has, are they sending it out for decontamination? Do you have a good supply? In the facility that I do some acute care, they're trying to cohort certain therapists are in the high-risk situations, and certain therapists they're trying to keep as far away from that as possible. As far as I have read from ASHA's statement, they're not saying exactly what to do, but they are trying to have anything that's not urgent be done telehealth as possible, and using as much extreme precaution with the PPE as your facility will allow.
Right. In my research for this segment and about this Skagit Valley coral story, I came across an article, a research study published last year in Nature, in the journal Nature, which is sort of a huge, broad spectrum science journal. And it actually was looking at influenza and the production of aerosols in speaking individuals, and how basically some individuals can be super emitters. And just by the dynamics of how their lungs and voice box and airways work, they're actually like mega producers of these aerosol particles. And I thought it was kind of timely. It was about about 1 year ago is when this thing was published, and we can show a graph a little bit later, but it looked at basically different volumes of speech amongst men and women, and the louder the speakers were, the more the sort of aerosolized particle count was for those patients. Dr. Johns, has this ever been a consideration of yours before?
It really hasn't, and but now we've known this. So we've known that vocalization can lead to both droplet production and aerosol production. It's the aerosols that are particularly concerning because they can linger in the environment and they can travel for longer distances. And so we've known that. It makes sense. So when we produce voice, it is a complex aerodynamic phenomenon. And the louder we generate voice, the more significant these aerodynamic forces are in terms of aerosol production. And it's not particularly surprising. So what happens with vocal cord vibration, we basically pass air from our lungs, which then comes up to the laryngeal level, and the vocal folds or vocal cords come together and they oscillate. And these complex aerodynamic factors, as it turns out, there's really good work that's been done by one of our colleagues, Sid Khosla, that demonstrates that there's these vortices, there are these little tornadoes that develop right above the vocal folds that lead to regular oscillation of the vocal folds in sound production. And as we get louder and louder, these vortices are more prominent, and you can imagine that would just stir up aerosolized particles. And so we've known a lot of this, and it hasn't really been there hasn't been a lot of clinical ramifications of that because we were largely in situations where we didn't have kind of an uncontrolled pandemic. So it really has been brought into the spotlight. How could voice production, could communication be an increased risk? Of course, all of the situation with the really unfortunate situation of this chorus, these are we got to take everything with in complete context. We really don't know what the specific risk is of vocalizing per se. In general, there's other variables that are involved, right? A bunch of people are collected together. Certainly, if you're vocalizing loudly in your apartment all by yourself, the likelihood of you infecting someone else is really extremely limited. So it's what is the risk when other people are around. So we just don't know how that's going to sort of play out in the short term. Certainly in the clinical setting, where a lot of institutions, and ours including, are doing universal masking protocols. So basically, as soon as you arrive at a facility, your cloth face covering is replaced with a surgical mask, which does reduce droplet spread and likely reduces some, but it certainly does not eliminate aerosol spread to try to mitigate some of those issues. But the real risks, for us is likely the procedures that we're doing that generate aerosols, like coughing. Remember, coughing, vocalizing, sneezing, they're all in the same kind of family of kind of aerodynamic activities.
Right, yes, thank you. Yeah, thank you very much. So I don't want to take up too much time this morning. Everyone's kind of gotten an earful and has a basic understanding of this concept. Eva, can you leave us with a couple of points that someone should consider, vocal health tips, basically? How can we all keep our voice as strong as possible during normal times as well as unfortunate pandemic times?
Right, and a lot of singers are understandably itching to make music with others again. And this made me think, just as Dr. Johns was talking about some of the precautions that we took in the past in large choral settings like the Atlanta Opera Chorus, where if you were sick and recovering and you could still be there, you were not contagious, you were isolating yourself 10 or 15 feet behind your section and you're still listening to everything happening. Whereas if you were actively sick with a fever, you didn't come in. But even now, if we start getting back together and start making music, are we supposed to be 6 feet apart? Are we masking? It's very hard to sing. It's even sometimes hard to breathe as efficiently in an N95 if anyone has tried to vocalize. Or perhaps I'm the only one that's tried to sing in an N95 mask. But right now, everything that you can do is just keep making music if you're a singer. Keep listening to music if you enjoy music. Keep talking. If you are not a musician, whether that's picking up the phone, doing FaceTime, doing something to use your voice. I think I've always been an advocate of just being vocally active. There's something cathartic perhaps in just the act of singing, whether or not you're really dealing with a lot of canceled gigs. My husband is a professional musician, and so he knows all about canceled gigs for the next several months. Opera singers, musical theater performances, things like that. If there's something that you can keep doing vocal on a daily basis. There's also just the other things of continue to drink your water, use your saline nasal sprays, breathe in your steam, do any of those things that just continue to make you feel better, more hydrated. If there's a fear of contracting the virus yourself, you're doing as much as you possibly can to keep yourself hydrated, moist, everything that you can feel comfortable and continue using your voice.
All right, thank you. Dr. Johns, can you, I'll let you get back to the beautiful Southern California sun. Can you give us the last word and last thoughts of the morning?
Well, one thing that has become clear is we're doing the right thing with social distancing and the public health precautions that we've been taking until we get some better sense of what's happening with this disorder. Make sure that we've got hospital capacity so that we can actually take care of people who need the care and have appropriate protective equipment. And once we have a handle on these variables and some more of the testing and immunity, then I think we'll be able to slowly be able to ease the brakes in appropriate, well thought out ways to make everyone get a little bit back to normal in a way that hopefully will happen sooner rather than later. We'll see.
All right. Thank you both, Eva and Dr. Johns. Excellent conversation this morning. I would like to leave you with this, our longest show so far, with just another quick review of our Georgia statistics. As we close today, we'll come back Thursday morning, 9:30, with a few more stats, news updates, etc. Thank you very much for tuning in. I'm Dr. Rogers, Advanced Ear, Nose, and Throat. Thank you.